ad hoc. Excellent. All right, you said intermittent lights, but
Oops, it's really dark.
yeah, I know. Are you can drive okay?
I think I can drive.
Okay. Oh, wait, the camera's not on. Hold on. Let's see.
Bruce is doing differential on the whiteboard.
Yeah,
Or
yeah,
like
just
each
that.
other.
Well, because it was going back and forth
I
in the
see.
camera. Yep, okay. Let's just give that a second. Yeah, I thought we were all prepped and I forgot
That's-
one thing. We need a checklist. Very promising.
Seems like it's a dead screen.
Yeah. Good warm up. Let's see. You're sharing here. The video's on. Oh, no, that is- Well, it's not getting the feed right now. Let's try the video. Huh. Are you working off,
Yeah.
is that the same one? Stop sharing initially. Maybe stop share first. Let's see here. Oh, there we go. Okay, now we're on the PC. Okay. Yep. Sweet. All right,
Well done.
sorry
So you
about
got
that.
yourself and yourself
Okay,
all.
very good.
All right, thank you all for sharing with us. We'll start rolling through things here. I have no disclosures, CME code is coming up right here. All right, so my talk is called Forging Ahead. One liner here, we have a 77-year-old female, history of poorly controlled type 2 diabetes. She has CLL and recurrent nephrolithiasis, presenting with abdominal pain. So for her history, she's been reporting right-sided flank pain as well as dysuria for about 5 months. Initially, she tried to treat herself at home with some leftover antibiotics she had from a dental procedure several years ago. She thinks it was maybe clindamycin, but can't quite remember. She was seen at an outside hospital clinic about 1.5 months before admission. She tells us that a CAT scan there showed stones on both sides and that her urine grew just yeast. She says she was prescribed ciprofloxacin and fluconazole with plans for urology follow-up, which unfortunately hasn't happened yet. And then several days before admission, acute worsening of right flank pain, dysuria, and fever. So she came to the ED. She did deny any hematuria. In terms of her history, she has type 2 diabetes. Like I said, it's relatively poorly controlled. She has CKD, and then she also has kind of smoldering CLL that she's never been on treatment for. Socially, there's nothing too significant. She's a never smoker. She's relatively functional for her age, endorses a pretty poor diet, and then she's a Jehovah's Witness. No family history of kidney stones or infections or immunodeficiencies that we know of. Medication-wise, she's on no immunosuppressant and has never been on treatment, like I said, for CLL. The only relevant kind of antibiotics have been Cipro and Fluke for about 2 weeks. And like I said, it was about 1.5 months before she came in. Physical exam, she didn't look fantastic. She's markedly febrile, 40.9, tachycardic, but with blood pressure that was at least hanging in there. Tachypnic and setting well on room air. Overall, like I said, was in pretty decent distress. She was diaphoretic and had some evidence of maybe chronic illness as well, a little bit cachectic. Otherwise, pretty dry mucous membranes, no cervical lymphadenopathy. She was tachycardic with an irregular rhythm, but no murmurs. Her lungs were clear, but she was working pretty hard to breathe at the time she came in. Belly was soft, pretty decent palpation, tenderness to palpation, right lower quadrant, suprapubic area, but again, no inguinal lymph nodes palpated. Really exquisite right CDA tenderness without any midline tenderness. CAB refill again is a little bit delayed, and then neuro exam, relatively benign, although she is chronically blind in the left eye, which I believe is just from a cataract machine she had. As far as labs go, her white count was 17.7, it's 47% lymphocytes and 11% bands. I think this was a little bit above her baseline leukocytosis given her CLL. She's somewhere in the range of like 13 to 15, but this is a new lab shift. Hemoglobin was 6.6, platelets were 347. Iron labs in the setting of her anemia showed pretty profound iron deficiency with an elevated ferritin, a low TFSAT. Creatinine was 4.5 from a baseline of around 2, mildly acidemic as well, but bicarb of 18. Glucose was 522, but like upper limit of normal and iron cap. UA showed really impressive pyuria, 213 whites per high power field. She had leukoesterase, negative nitrites. It also noted many budding yeast and occasional bacteria. Her A1C was greater than 16 and her lactate was 5.2. So that's what we have for now. Let me just look at the chat.
Okay, great. Yeah. Let me just take a look here. Participating today.
Seth, can you unshare your screen?
Yeah.
Thanks.
Would Andrew Caraba, are you free to give some initial thoughts on this case? Okay, 1 second. Need to put my headphones on. Okay.
Hi, Paul. Can you hear me?
Yeah, sure can. Thank you so much.
Great. Yeah, I'd be happy to, but I have to say I missed just like the very first slide. I'm assuming I heard something about CLL, but I later on, but I missed the initial, just the very first slide. This was a woman with CLL, but she was not on any chemotherapy for the CLL. Is that correct?
That's right, and then it seemed like a pretty low acuity CLL that's just kind of been monitored.
Got it. And it was the initial presenting complaint was the right-sided flank pain. Is that correct?
Yep, and dysuria for about 5 months that acutely worsened a couple days before admission.
Got it. Okay, so so we have a 77-year-old woman with CLL and poorly controlled diabetes presenting with a sort of subacute right-sided flank pain, coming in with sort of a septic appearing picture. So I'll start with viruses briefly because being a virologist, I always think of viruses first. But I don't know that a virus explains this. The stuff that comes to mind is, could this be like EBV or HHV8 driven malignancy? I suppose that's possible, but it'd be a little bit of an acute presentation. Adenovirus can certainly make people like very ill like this, but it wouldn't necessarily explain all of her symptoms. Did we hear what time of year this was? Is this a recent case or from another time period?
I'm unfortunately not allowed to say that. I think it's a HIPAA thing with recruitment going on. Sorry.
So you can't say like summer, fall, anything like that?
I don't think so, no. Correct me if I'm wrong,
Okay.
Natasha, sorry.
Sorry, Dr. Caraba, but that is correct.
All right.
Good test though.
I was gonna think like West Nile virus maybe could make people with CLL pretty sick, but wouldn't really present with right side flank pain like that. I'm gonna stop there at viruses, and I'm gonna move to bacteria. So this could be a usual sort of UTI type pyelopathogen like E. coli or Klebsiella or Serratia or Proteus, but I suspect that you wouldn't be presenting this case if it was something like that. CLL patients with CLL sometimes have difficulty with particularly encapsulated organisms like strep. I've seen some like invasive strep pneumo disease in CLL, or as like a presenting sign of a presenting symptom, I guess, of CLL or other hematologic malignancies. So it's like salmonella I'd put up there too as a possibility. And then moving to sort of like atypical bacteria, as we all know, TB can kind of present like anything. So, but I didn't hear a lot in the history about obvious TB risk factors. So I think that's a little bit less likely, and NTMs would be like kind of aggressive for an NTM. Other atypical bacteria, sort of some like more exotic things that can make people pretty sick, like tularemia or Yersinia, I think are unlikely in this case. The sort of thinking from atypical bacteria to the next category, which was going to cover, which would be fungus, something like a nocardia or actinomyces. Certainly, like we see people get pretty sick from nocardia, but the presentation is usually either pulmonary and or CNS, and this is more like right-sided flank pain. So I think that's a little bit less likely. And then fungi, particularly with the out of control glucose, makes me think of like mucor or rhizopus. Other fungi that can make an immunocompromised person quite ill would be something like histoplasmosis or blastomycosis. So I think blasto is unlikely. You didn't tell me like where this person's like local in the sort of mid-Atlantic area. Is that correct?
Yeah, Maryland, you can say.
Yeah. So histo more so than blasto then. There's always popular fungus NOS, but I actually think that we probably don't need that here because other than the CLL, I didn't hear a lot of other immunosuppressive type things going on. And then non-infectious etiologies. So something like a malignancy like the CLL could have progressed, or we could be talking about, a primary renal cell carcinoma that's then causing sort of an obstructive pyelonephritis type picture. And then going back to the fungus for a second, this like process is, I think I'm going to screw up the names, like xanthomus something. There's an X in it, and it's basically where like a fungus just like takes over your kidney. I can't remember if I personally have seen it, but I remember there being a case of that on one of the services. Xanthograminous pyelonephritis. Thank you very much. That's the other thing I was going to put up. So I'll stop there, and I'm happy to hear other people's thoughts.
Yeah, great. Thanks so much, Andrew. Comprehensive list. I don't know if you caught that the patient was on fluconazole for a while, and that yeast or budding yeast had been identified in the urine.
Yeah, I saw the budding yeast in the urine, but budding yeast in the urine is like, particularly in someone with diabetes, is like big deal. The lab's open.
Okay, fair enough. Pranita? Encrusted, so Corynebacterium, Urolyticum. Okay, so got that one. Any other suggestions, Natasha, if you want to?
Yeah, I'm monitoring the chat. Nothing new yet.
Nothing new. Okay. Definitely an indolent presentation.
Benita, did you say anything other than the Carini? Sorry, I couldn't hear. Okay.
How are we doing?
Actually not up there.
It's not up there.
Oh dear.
Okay.
Did they spend time abroad? This patient spend any time abroad?
No travel outside Maryland.
You could still have Candida resistant, some with a Candida resistant species. I'm sorry, azole resistant species of Candida. This is dark Candida aureus. Just kidding, angiosarcoma. Okay. I don't know, if it's guessing the bug, we're not doing so well.
Well, it's up there now.
Oh, it's. Aha.
That's why you're here, Paul.
Yeah, okay, all right. Well, I don't think we have to vote then. I think that's true. So why don't you go ahead?
Sure.
Thanks so much, Andrew, for discussing.
All right. Let me read back up. Okay. So for the patient's initial course, she was started on vanco and cefepime while in the ED with concern for like ascending pyelonephritis. CT abdomen pelvis showed a moderate right hydronephrosis and right pyelonephritis due to obstructing calculus, as well as multiple left-sided stones as well. Urology was consulted. She was taken for emergence IR percutaneous neph tube placement with the drainage of grossly purulent urine. Kidney abscess culture and 2 out of 2 admission blood cultures ended up being positive for yeast, which eventually speciated to Candida glabrata. She was started on fluke and mycofungin. And I know, sorry, I can't feel like I kind of put Andrew on the spot. It's not like, the reason I decided to talk about this case isn't because of the Candida, although it is interesting that she retained it after having the fluconazole therapy and the setting of these indwelling stones. Things started to get a lot better for her in terms of her hemodynamics, but her hemoglobin remained low and the patient was a new renal failure. So we actually got asked by nephrology here, what are the risks of giving her IV iron, especially with her being a Jehovah's Witness in the context of this ongoing infection. There was a lot of risk-benefit discussion about what to do next in this case. So this kind of brings up this concept, and there's the big clinical question I had for this, is when can IV iron administration be considered in the context of an ongoing bloodstream infection or of sepsis? This kind of brings up this idea of nutritional immunity, which is basically this concept of how the host organism sequesters trace minerals, and I think we especially think about iron being important in this context in an effort to limit pathogenicity during an infection. So it's kind of like a busy graphic, but it's probably the one I like best, showing the 2 different paradigms of iron metabolism, which is a really complex process in mammals, and especially in humans. On the left here is the more like the normal, the iron deficient state with kind of the free flow of different forms of iron through the body and being incorporated into different tissues. On the right side, it's this iron overload, which is a really similar mechanism to how the body reacts to an active infection. And it really centers around this axis of hepcidin and ferroportin. I like this graphic the best. I don't think it's like mechanistically exactly true, but it just kind of shows how it plugs up all these potential exporters and tries to keep iron sequestered in tissue or in the gut and not floating free in the blood. And I think the concern for this and why there isn't a ton of data about it is that there's been this mechanistic idea that as you increase the concentration of free iron in the blood, there's going to be this fertilizer effect where you just kind of get unchecked microbial growth, which seems like not a great thing to do in the context of a severe infection. But I think more recently, there's been a lot of thoughts to the alternative side where we're seeing therapeutic iron, especially IV iron, being used in a lot of clinical contexts, obviously in like iron deficiency anemia, but also things like heart failure, where there's just some type of imbalance between tissue oxygenation. Additionally, there's a lot of mechanistic evidence that the immune system really needs at least a baseline supply of iron to be able to react appropriately to invading pathogens. So the question kind of is where this balance is and how we reach it. So we looked at a lot of different evidence for this. There's not a ton of really satisfying data out there, but maybe the biggest study that came out pretty recently is a meta-analysis published in JAMA last year. Huge meta-analysis looked at RCTs and non-randomized studies from 1966 to 2021 that compared IV iron with oral or no iron, and they had to report infection data, and they kind of looked at what resulted from all that. So you can see the picture on the right is the weights of the meta-analysis curve. You can see it's just barely ticking over towards the side of not giving IV iron being associated with better risks of infection. So they found the relative risk was 1.16 of giving IV iron increasing the risk of infection, which I'll talk a little bit more about in a bit. In subgroup analysis, they did note that it was much worse in people with IBD as a specific population. They found no big differences in mortality or length of stay in terms of the 2 groups. And they did find that the kind of baseline assumption that IV iron improved hemoglobin levels and red blood cell transfusions wasn't met. The big issues with this is that there was a huge variety of studies that looked at everything from ICU patients to those with CKD or dialysis patients to elite athletes. There really wasn't any type of standardization on how infection was defined And most of the studies didn't specify the site, the severity, or the pathogen of infection. So it's tough to know how much clinical utility we can draw from that, especially in this situation. Maybe a little bit more targeted of a study. It's a pretty interesting one I found in the Journal of Intensive Care from 2020. This is a prospective single center study from a hospital in Helsinki. It followed serum iron markers and SOFA score, as well as mortality in sepsis patients. What they found was that serum concentration of iron and concentration of ferritin were correlated with increased SOFA scores and mortality. Specifically, they honed in on this transferrin saturation, which is a marker of a kind of a surrogate marker of iron overload in the blood. You can see here from this graph on the left that higher transferrin sat was associated with reduced survival and pretty significant. They did interestingly find as well that the administration of blood products, including packed reds or some coagulation factors, prior to the ICU transfer led to an elevated TF-sat and independently led to reduced mortality as well. So I think it's kind of interesting because I know we think of IV iron as this just almost like unchecked fertilizer thing, like I said, but red blood cell transfusions in a septic patient are definitely not something that's unheard of as we're trying to balance mortality and infection risk. In the end, they suggested transferrin sat as a standalone predictor of sepsis survival to kind of be incorporated into these sepsis predictor models that we have. I tried to look even a little bit closer at Canada specifically. Unfortunately, there's not a ton of clinical data about how iron balance affects candidal infections in humans. I think because there's kind of been this taboo against looking at it, given that there's a ton of basic science and mechanistic evidence that Candida is really uniquely sensitive to iron balance. There's a bunch of basic science papers that look at like experimentally inactivating iron assimilation mechanisms, which attenuates the virulence of yeast organisms. There's an interesting paper that Sarah Grauber and I were looking at for a while that showed that iron overload exacerbates the progression of candidiasis in mice. Interestingly, though, kind of looking at the hereditary hemochromatosis literature that there is out there, I think we think of those things like Yersinia, Vibrio as being really unique infecting pathogens in these patients. There's not a ton of specific data looking at the risk of candidiasis or other fungal infections as well. I think it's one of those things that also is just kind of an assumption that it worsens the infection. And then this figure on the right is from that paper. It looked at both mice and human models, and they found these just really immense shifts in iron homeostasis and where iron was stored in the body that went down to a genetic level in both humans and in the infecting organisms. You can see here there were pretty profound shifts seen from iron storage in the spleen to being stored in the kidney in the context of like an active Candida bloodstream infection, which especially in this case with the lady with Candida abscess in her kidney seemed pretty non-ideal. So what we ended up saying here is that it's probably not a good idea in this case, at least at the outset of the infection. But again, we didn't get the super satisfying answer here. So what happened with the patient? She ended up taking 5 days and 3 full sets to fully clear her blood cultures. She was maintained on mycophenolate for the candidemia and then fluconazole for renal penetration. I believe the sensitivity data actually came back that the Candida species was relatively susceptible to fluconazole. I think it was just an issue of source control with her routine stones. That's why she reseeded after finishing her therapy. They ended up placing intravenous catheter. When she finally cleared, she's now dialysis dependent, unfortunately. Her course was complicated by these recurrent episodes of leukocytosis, giving her, we decided to give her intermittent antibacterial coverage for fear that we were kind of missing something. She had 2 TTEs that were negative on hospital day 12 during another one of these kind of septic appearing episodes. A CT abdomen pelvis noted a new splenic infarct versus abscess. She very gently refused TEEs or aggressive surgical interventions. So we kind of just had to plan on putting her on empiric lifelong fluconazole prophylaxis for presumed endocarditis. And unfortunately, although nephrology was very aggressive about alternative measures, including EPO, her hemoglobin ended up nattering around 5.5. She started to get relatively symptomatic. So we did end up saying it was probably okay to give IV iron in that context after she finally cleared. Here's a couple of teaching points and then the references. I think there's a couple minutes left, so I'd love to hear if anyone's had more time to think about this issue than I have. So I know it comes up relatively frequently in practice.
Sean, thanks. See if there are any questions. On the single center study, how do they account for the anemia of chronic disease? Iron metabolism at that point and trying to divorce that from pure iron deficiency and an acute infection.
Yeah, so I think they didn't.
They did not.
No, it was just all comers, and I mean, most people will have a really elevated ferritin by the time they get to the ICU, I think
Right,
either way.
yeah, exactly. So, and sort of like this lady, right? I think her iron level was low, but her ferritin was sky high, right?
So, yeah. But I think the transferrin size is like a little bit of a more subtle marker than, so I think it reflects more acute changes as opposed to the ferritin and the iron level.
Yeah, I think it's a hard thing to address, and I think when someone's severely ill, iron's going to take a number of days to longer to make it move the needle on her hemoglobin and hematocrit. So the urgency there does not seem to be acute. Whether it clinically works, as you said, it looks like the studies were all over the map.
Right.
And, you look at that, what does the meta-analysis tell you? Almost nothing, right? Try to pick out what you think are to me, I always look at those and say, what are the best quality studies? Because that's going to be subjective, but you could do that too. But a lot of the meta-analyses don't really, unless if they indicate that they have some sense in the discussion, you don't get a real viewpoint without going through all those yourself.
Right. That was a lot of studies.
Right, there were.
Hey, Paul, it's Yuka. At the risk of being potentially tangential, I would say that for intracellular organisms or organisms that spend time within a cell, for example, tuberculosis, there's a portion of the genome that's devoted to siderophores. So I do think that for intracellular organisms, there might be a better case to be made. I studied iron-regulated genes with Bill Bashai when I was a postdoc, and I remember reading stuff about Somali nomads that were sort of iron deficient, and given iron, suddenly they reactivated their tuberculosis. It was kind of an interesting series, but same thing for Brucella you can find. So maybe these organisms that spend time within a cell, we might make a better argument, not sepsis like this. So like I said, potentially tangential, but interesting.
And then like Borrelia doesn't use iron at all, right? So it really is this kind of, yeah, it's a great point that it probably is really organism dependent, but there's just not a ton out there to guide us.
Yeah, I mean, it'd be very hard to address this question, I think. But
Cool. Thank you. I can give Sishan a little more time.